Go?
Yeah.
Okay. All right, we're going to begin. Dr. Enders, I'm part of a small private practice, AZ Ortho. I'm sure some of you have seen some of our patients. My partner, Dr. Kavanaugh, started the Jiffy Knee. That's a huge thing here in the Valley now, so a lot of people are nodding their heads. Yeah, we've seen the Jiffy Knee. It's very popular. My journey and a lot of what I'm talking about today kind of deals with all of that. When I saw him doing the Jiffy Knee, I saw the results that he was getting, A, but B, just how rapidly he was getting busy too. And selfishly, I wanted to get busy, so I was trying to think of something that I could do with the shoulder that could kind of mimic the Jiffy Knee. And if you don't know what the Jiffy Knee is, it's a muscle-sparing approach to the knee, similar to the subvastus, but a little bit different. It's more soft tissue, and realistically, what it's doing is you're not violating your extensor mechanism, so the recovery, they're not healing from the joint replacement on top of your extensor repair, but more just a soft tissue repair. So what they've seen is just a quicker recovery, quicker return to function, quicker motion, all that stuff. So, you know, ever since he started doing that, I've been trying to think about, okay, what can I do in a shoulder that mimics that can replicate that success? And I'm in the infancy of doing that. But that's one thing I wanted to talk about today. Another thing is the in-space balloon, which is another kind of newer technique that I don't know if you guys have had much experience with. I've been doing that since July of 21. It's a surgical procedure for irreparable rotator cuff tears, which, as you guys know, they kind of fall in the middle of, well, do we repair or do we replace? Which is kind of a shitty option if they still have good good cartilage and not much arthritis. So my talk today will be centered on both of those things. Started with just the three of us, myself, Dr. Kavanaugh, Dr. Larson, he's our foot and ankle specialist. We're now up to 5 providers. We added Dr. Adams, who's also doing the Jiffy Knee on the west side, on the east side, and Dr. Sepich on the west side. So this year we opened a new office out in Peoria. 101 in Thunderbird is where it's located. I've bounced around a lot. I've done more school than most people to get to here. I've lived in 12 different states. So I have a big background in anatomy and cartilage research and stuff like that. Here's some of my papers, just a little bit about who I am. Surgeries I perform, I did a sports fellowship, so with sports we're kind of generalists. We do a lot of surgeries. You know, nowadays with fellowships everybody gets such in their niche that they only do hip or knee replacements or only do peds or only do onc. I feel like sports guys, we still do a lot of other stuff too. I still take call, I still see a lot of fractures. But my fellowship was on arthroscopy, so elbow, shoulder, knee, ligamentous issues, stuff like that. But the fellowship that I did was also very heavy on shoulder elbow. I did a third of my rotation on the shoulder elbow service, which means a lot of joint reconstruction, a lot of shoulder replacements. So I've always liked the shoulder. It's always been kind of my sub niche within the niche of sports. So it was a perfect fellowship for me. As you guys know, trying to tuss out what the cause of the shoulder pain is very difficult. Many different things in this area can cause shoulder pain. So we always got to look at the neck. You got to think about the tendons, arthritis, impingement, which tendon it's going to be. So it takes a little bit of work. Why the shoulder has always kind of fascinated me and what drew me to it is it's a very unique joint. It's very different than a hip or a knee or an elbow. It just has a lot more motion to it, and that's just because of our anatomy and how we're built. The static stabilizers are your joint capsule. They're not very strong. They don't do a great job. And really, it's the dynamic stabilizers, such as your rotator cuff, and the 17 other muscles that attach to the scapula that all kind of help us do this. So it's just an inherently unique joint. In trying to treat it, you have to take a lot more in. You have to think about a lot more when you're treating it. Rotator cuff, everybody knows what the rotator cuff is. It's 4 different tendons. The main job of the rotator cuff, which I always tell people when I'm talking to them, is a humeral head depressor. It helps hold the humerus down in the joint, and concavity compression to allow it to move in all the planes. Usually that's responsible for the first 30 to 45 degrees, and then the deltoid takes over and functions here. However, I'm sure many of you have seen people with full thickness tears that can still do this, and people with partial thickness tears that are kind of right here. So there's a lot of compensation that the body does, and it can be very confusing because you can see someone like this, a full thickness tear, And they're doing great. Why would I touch that? I'm not going to do anything for that. Here's just some of the physics behind how it works, how it is a humeral head depressor, the supraspinatus specifically, and that concavity compression. I talk a lot about the rotator cuff to patients because we see a lot of it, and it's very common as we age. But it's a spectrum, and most people, when they come to see me, they don't have a traumatic, I fell, outstretched arm and tore and hurt something. Most of the time, I woke up one day, my shoulder's been hurting, and it's getting worse. I don't know why. I don't understand. And it's a spectrum of fraying to partial tearing to full thickness tearing, just depending on the chronicity. Impingement, when I see these MRI reports all the time, I'd say 90% of the time it's the supraspinatus up top. And it's because of that impingement. If you imagine 20 years of pinching that tendon against the acromion, not 20, 60 years of rubbing that tendon against the bone, it's just a war of attrition. Not to mention that over time, all of our healing factors, our vascular factors, growth factors, all the things that kind of help us deal with that insult go down. Which is another reason why when you're talking about PRP, I'm off subject here, but PRP, when you're giving PRP, you're using their growth factors and their vascular factors. Well, if they're 70 years old, it's going to be kind of shitty, right? They're not getting good stuff. We actually use a company that uses umbilical cord blood. So you're getting fetal and maternal growth factors, vascular factors. They've measured it, and it's exponentially higher than what an adult over the age of 20 probably has, honestly. And most of these people are in their 60s and 70s. So you're not getting a good product if you're using their own stuff, I feel. And it's very common. So, once you hit 60, depending on the paper that you read, the incidence of having some type of tear on that spectrum is about 1 in 4, 1 in 5. When you hit 70, it's 1 in 2. So I also tell people this to tell them, I'm not operating on every other patient that comes through my door. There's things that we can do. You can function even just because the piece of paper says you have a tear doesn't mean we have to rush right away to surgery. Let's try some physical therapy. Let's try some injections. Let's see if we can get some compensation from those other muscles before we get that. Now, I'm a surgeon. This is a surgical talk, so eventually we get to surgery. Another thing I also tell people, you're weighing things, and my practice, I don't really dictate you have to have a surgery. I give them their options, and I let them think about it, and I help them, guide them on what I think the best option will be. 50% of these asymptomatic tears become symptomatic in 2 to 3 years, and 50% progress within 2 to 3 years. So the other things to kind of think about. I think over the past decade, we're starting to become more aggressive again with fixing these. A lot of times it was physical therapy 6 months. Give it 6 months, see how you do, right? But now looking at what happens over that 6 months, especially if you have a full thickness tear, it's not going to magically grow and heal, right? And so if you can get to a full thickness tear quicker, I'm a little bit more aggressive with those. Now, partial thickness tears, I'm still pretty conservative. Let's see how you do. But full thickness tears, I don't want it to retract. I don't want it to atrophy to the point where it's irreparable, and then you're stuck with either this or this. Ideally, if you can repair the rotator cuff, I think in the long run, even though it sucks more up front, it's a better option. Things that I'm always considering and counseling my patients on are, the different risk factors and the repairability, and a lot of these different things kind of go into my mind as I'm thinking through, okay, is this a fixable tendon? Do we do an injection? Do we think about a balloon? Do we think about a shoulder replacement? And so some of the modifiable risk factors are things like diabetes, smokers, heavy alcohol abuse, stuff like that. As patients get older, over the age of 65, we know that their likelihood of success after a rotator cuff tear starts going down. So that's another thing you have to think about. How far that tear is retracted, how much atrophy there is in the muscle belly and the tendon, those are all things. So the Gedalia classification I use frequently in my practice when thinking about how to fix a shoulder. I don't know, have you guys been exposed to this? Have you heard of this? So on an MRI, there's a whole classification scheme looking at the fatty atrophy of the muscle. And the cutoff is really between 2 and 3. Stage 1, stage 2 means that they have more muscle than fat. If it's been torn and not attached and retracted for a long time, eventually it starts to get replaced by fat. Well, we've learned that these stage 3, stage 4 Tendon repairs, if you try and repair it, it just has a much higher chance that it's going to fail. So we're just putting sutures through it. So if that tissue quality is poor, it can rip right through it, right? So those are things to consider too. If I see it stage 3, stage 4, I'm leaning more towards one of these things versus a repair. Now there's a lot of different things still coming out to this day in our tool belt that we can use to fix. And so one of the things that I wanted to talk about was the in-space balloon. The in-space balloon, it was developed in Israel in around 2010, and then it was used in Europe for over a decade before it got approval here in the United States. I remember reading about this thing in residency and, oh, this sounds great, why can't we do this? So July of 21, it finally got approved here in the US. I've probably done maybe 40 since then. It's a very narrow indication to do it. But the people that I've done it in have done great. And I'll show you some videos here coming up. But this is the technique. It's arthroscopic. It's quick. It probably takes 10 minutes to do. And what you're doing is you're going in, you're measuring. Based on your measurement, you'll choose the size of balloon. It's basic. I liken it to a breast implant. It's a little sac that you put in the subacromial space. It's meant to kind of replicate that function of the supraspinatus, so it's a humeral head depressor. So it helps with function, but B, it also helps with pain because your greater tuberosity isn't rubbing up here against your acromion. And so all you do is you go in, you put this little balloon arthroscopically. This is actually the inserter. You pull this back, you flip this up, and you fill it up with saline. Takes 10 minutes. Afterwards, it's not held in place by anything, which is interesting too. Afterwards, it's a sling for 4 weeks to kind of let that thing scar in. Because like I said, it's not held in place by anything. And then they start moving. And I've seen people get back very quickly their motion. And they're not going to have the same strength that they would with the normal shoulder, but it's going to be better than it was prior to. And to me, you're not burning any bridges, right? It's a quick arthroscopic procedure. This balloon is biodegradable, so within 10 to 12 months, your body will reabsorb it. However, the data from Europe shows that 5 and 10 years after the surgery, the motion is maintained, the function is maintained, and the pain relief is maintained. So the next question will be why or how, right? I don't think we really know how, but I think it's kind of resetting the tone of some of the other muscles that are still intact, which is also why these people with full thickness tears can still do this. I think if you can push the humeral head back down and get the infra and the supra and the deltoid and all the surrounding musculature to kind of tighten up and reset that tone to what another person with a full thickness tear can do this too. I think that's partly how it works. I think it also forms somewhat of a scar ball in that area. So another procedure that I don't do, similar concept to this is a tuberoplasty or tubercleplasty, where they put a little graft over the top of the greater tuberosity for these irreparable cuff tears. And I think that's just helping with the pain from rubbing up against the acromion, because they're not big, they're thick. Or they're not thick, they're tiny. And so it's not really filling up that space like the balloon does. Now the indications for the balloon, well, here's some more kind of background behind it. Minimally invasive, quick operative time, like I said, 15 minutes for me to do. Quick recovery. So they've been looking at this. They've done a number of studies. Like I said, in Europe, they showed good midterm studies at 5 and 10 years. Recently here in the US, they've been looking at this, and they compared it to a partial rotator cuff repair. What they saw is that there's just a quicker return to function with the balloon as opposed to a repair, because you're not waiting on something to heal. So contraindications, reasons not to do the balloon. If they have significant arthritis, they're still going to have a pain generator. So this isn't going to take away all of that. Active infection, allergies, those are kind of no-brainers. If the subscapularis is torn up front, that's kind of one of your restraints to holding this in place. It could potentially slide out the front. I'll get to you in a second. I've seen one extrusion, and it was partial. And so the lady has a little bit of a bump here. But she was doing great. Her shoulder was still moving great, and she still had good pain relief. So I said, why? Why would I go do anything if she's doing okay? It's a little cosmetic. It will reabsorb in 10 months, and then that'll go away. So I decided to leave her, and that was the only one out of 40-something that I've done. What's your question real quick?
Well, I had a patient that had some necrosis of that humeral head, and the surgeon she was speaking with I'm just curious if, I don't see that as listed, but other than maybe the significant arthritis category, would you be depending on the trial?
That's a zebra. Yeah, that's a little tough. You could potentially treat the necrosis with, as long as it didn't involve the cortex, if you have like a little subchondral sclerosis and stuff, with injection of cement to kind of, or bone filler to fill that void to kind of help induce some bone growth in that area. But as long as the articular cartilage and the cortical bone were still intact, then I would still say this would be a valid procedure.
And then you could still do the rotator cuff later if you chose to, if it didn't fail or something? Or?
Not really, because this is my salvage procedure. I do this when I think that I can't repair the rotator cuff. So those Goutellier 3 and 4s that I know have a high incidence of failure, but they don't have arthritis, then this is the option. Okay, so that's all my talk about the in-space balloon. Quick procedure. I did have some videos though. Let me show a video. This guy, no, not this guy. I have a good before and after that shows what the lady's range of motion was before that surgery and what it was after. So on the right hand, or on your left hand side, that's before. On the right is after. Oh. And this was, I think, 6 weeks after the surgery. Why is it stopping? What's that? Does it? It says the one. That's great. DM. It does say I'm offline now.
Does it give you the option? Hold on, go to other networks. Maybe. Hit eWi-Fi. And then password capital SPOONER, capital ROCKS 23.
Okay.
Exclamation point. Our IT guys came up with it. It's a little.
It works, it rocks,
They're,
right?
they're corny.
No, it's tiny.
Dr. Enders, what's the rehab protocol like for that? You said they're in a sling for 4 weeks.
4 weeks in a sling.
Okay.
I start physical therapy at week 1.
Okay.
More passive motion below the shoulder. And it's maybe a couple months of physical therapy, but there's a whole protocol that actually Stryker has for this too.
Okay.
That I usually send them with that. Let's see if we can try that again. Huh.
That's okay. We can see it.
All right, you can still see it. So before and after at 6 weeks. If you can hear it too, she's in a lot of pain on the right. In the video on the left, she's just so happy. It's such a good thing. That's one. That was a before and after. I think I have another one with the guy that got back to. Oh, here's another one. This guy's at 6 weeks. Oh, 3 months. Sorry.
All right, so we got Mechanic Douglas here. We are 3 months out from the balloon procedure. How you doing?
Sorry, I'm doing a lot of talking here.
Sleeping well?
I don't know how to speed that up.
Looks like you might be kind of a repeat offender for easy ortho, huh?
Yeah. It's not uncommon. Oh, you've seen Kavanaugh and Larson. Okay. Just making the rounds.
What's your emotion?
And I have people back lifting weights within 2 months with this balloon. So the people do great with it. I mean, I've had maybe 2.
That was an issue
that could not restore the motion. And I think part of that is better indications with the patients, because if going into it, if they can't get their arm at least to shoulder height or higher with a full thickness tear, then it's hard to ask the deltoid to be able to make that up and get them up here. And a lot of times they can't. So I think more it's just patient selection than anything. All right, so next talk, I wanted to talk about my subscap sparing approach that you guys have the thing to. So arthritis, just a quick touch. We rate it on a scale of 1 to 4. 4 is bone on bone, 3 more than 50% loss, 2 less than 50%, and 1 very superficial. People oftentimes come in with MRIs and X-rays, or MRIs and CTs, and they ask why we need X-rays. But X-rays still tell us some information. Specifically, if you see superior humeral elevation like this guy, that picture, I know right away that their cuff is torn. They're not going to be a candidate for an anatomic. They're a reverse. I know that right away from seeing that picture. Have you guys heard Maloney's line? I don't know. It's a line. Oh, no. It's a line basically connecting the inferior border of the scapula to the humeral head. If you can look on this picture on the left, it's almost a smooth arc. If you see disruption of that arc and the humeral head is up here, then that tells you that it's a chronic rotator cuff tear. So that's something just on X-ray that I can tell, okay, you're a reverse. You're not an anatomic. Other things, so the big debate that I always go through is, okay, are you an anatomic or are you a reverse? When I first came out, I was doing pretty much all reverses because they've been doing great. But lately, I'd say in the past couple years, I've been a little bit more aggressive with doing anatomics and even a hemiarthroplasty, which is something I'll talk about also. Now, the reasons, what I think about when I'm looking at anatomic versus reverse, and most importantly, is the rotator cuff, as I'm sure you're all aware. If there's a full thickness tear, then you can't do an anatomic. The reason being, if you're trying to do an anatomic in a person that has a rotator cuff tear, you're not going to have that inferior constraint, so this will slide around. It'll rub up against the acromion. They'll be in pain, and they won't be happy. They'll come back and they'll need a revision. With the reverse was actually built for people without an intact rotator cuff, because you're changing the biomechanics of the shoulder, and now when the deltoid contracts, it just levers off of that glenoid and moves this way. So you don't need an intact rotator cuff for this to function. That's one reason. That's the number one reason. But number two, which a lot of people don't know about, is their dysplasia, the glenoid dysplasia. So, a normal glenoid should be almost perpendicular with the body of the scapula. If you're starting to get significant retroversion or even anteversion, then you're trying to build up and restore that joint line with plastic. And oftentimes, if it's significantly dysplastic, you're going to have a lot more plastic on one side than the other. And then that tends to a higher rate of loosening of this plastic piece. So the number one cause of revision for anatomic shoulder replacements is loosening of this little plastic piece. Because if it's eccentrically wearing against one area, then it's going to, this is just held in place by cement. We drill little holes and put cement in there. It's not screws, it's not metal. So these loosen, and that's the number one reason. So if I see significant dysplasia, even if they have an intact rotator cuff, I know that there's going to have a high incidence of failure, so I'm going to do a reverse, even with an intact rotator cuff. The Hamada classification, that's just a way for us to describe the superior elevation in conjunction with arthritis. You may see that in our notes or stuff like that. So I wanted to look at the history of shoulders. So they've been around for a while. The very first one was done in 1893, which is interesting. It was titanium or platinum and rubber. But they had horrible infection rates, and so they had to abandon it because they were not helping people at all. It wasn't until the 1950s that Charles Nair here in the US, he pioneered the first hemiarthroplasty, and that was for a fracture. However, they started to see high revision rates, a lot of pain still, so the hemi kind of fell out of favor. But his use of the shoulder replacement kind of led towards the future of where we are now. So that's that little platinum and rubber prosthesis that you see up there. This one in the middle is the very first anatomic, that's the Nair prosthesis. And then this is the Grammont on the far right-hand side. And it took a while to get that down. And we went through many different iterations and a lot of catastrophic failures, just trying to figure out the biomechanics and the physics about the shoulder to get this thing to not fall apart on them, you know. The first reverse wasn't done until 1985. So that's after I was born. It's relatively newer in terms of medicine. And it wasn't approved here in the US until 2004. So it's relatively young in terms of procedures that we do. Now, the rotator cuff sparing approach that I'm talking about today, I'm not the first one to think of this. That was actually done in Cincinnati in 2017. And the reason why it's not mainstream now and not everybody is doing it is because a number of reasons. So number one, when we do a shoulder replacement, to get into the shoulder to do our job, we have to take down the subscap, whether that be with bone or cutting the tendon or peeling it. There's 3 different ways to do it. Doesn't matter. But to get into the shoulder, you have to remove this somehow. But afterwards, you have to replace it or repair it by whatever means you do. So that's part of the recovery and the pain after a shoulder replacement is that rotator cuff. This guy, Dr. Greavy from OrthoCincy, he thought, okay, what if we go in this plane in between the subscapularis and the supraspinatus? Now that requires special instrumentation. I can't use the normal instruments that I do. And, you know, normally we're cutting from front to back. He had to cut from top down. So you're trying to keep your version, you're trying to cut at a 130-degree angle, you're trying to do all these things looking from top down versus straight on like you're used to. So it's difficult. There's definitely a learning curve. And you're working through such a tiny space. I mean, when we do the normal shoulder replacement, you're wide open. You got plenty of room to work. And even then, it's still hard to get in there and do some of the stuff that we have to do sometimes. So going through this tiny space, I've been learning, is very difficult, and sometimes you just can't do because whether it be poor rotation on the patient's arm or body habitus, if they're really meaty or very fatty, it's going to be hard to get your instrumentation in there. So it's still a work in progress for me. I think I've done maybe 18 to 20 so far. I try them on everybody. There's no harm in trying. If I can't, if I'm struggling, then I just cut the tendon and do it the normal way I used to do. This is kind of just a timeline in the infancy, really, of shoulder replacements. The hemi, I said I wanted to touch on this. So the hemiarthroplasty, people were still doing it, even some people still do it, with the old type of prosthesis, which is a metal prosthesis. Now the problem with doing that is that you're having a very hard metal surface that has a different modulus of elasticity than the cartilage and the bone. So it wears down the cartilage on the glenoid pretty quickly. And a lot of these patients come back not happy within a few years, wanting either an anatomic or a reverse. Stryker recently has come out with this new hemiarthroplasty that has a pyrocarbon head. So the pyrocarbon is much softer than the metal that we use in our standard prosthesis. And you can feel it. I wish I had one. They won't give me one because they're expensive. But I wish you could feel it because it is almost spongy. It feels much more pliable than the hard cobalt chromium that we typically use. And interestingly enough, too, what I've seen is that, you know, on post-op day 1 or in the first week or so, you're going to see images like this where there's not much space. Even if there's arthritis on the glenoid, there's not going to be much space. But over time, that space has kind of increased. And I don't know if it's fibrocartilage or scar tissue or what's happening at that interface, why you're getting more space, because that space classically is filled with cartilage. That's why we see the space. But it's an interesting phenomenon. And I think this is a great option for people that have an intact rotator cuff, have moderate to severe arthritis, at least on the humeral side, but not as bad arthritis on the glenoid side. So as you can tell, it's kind of narrow indications. I'm still not doing this on a lot of people, but there are patients where this is a valid option, and I think long-term this is going to be a great option for them. And that I'm still trying to do through the subscap sparing approach too. There's many different types of prostheses nowadays. Everybody's really moving towards this stemless implant. You know, the whole idea with the shoulders, you're trying to preserve as much bone as possible. In the event that you need to go back for a revision, you want to have enough bone stock there to use your instruments and have a successful surgery. So Everybody's kind of moving towards stemless now. And even with the stemmed implants, they're all pretty much convertible now. So if you have an anatomic done and God forbid you need a revision, you don't need to take out the stem from the humerus. You can just convert and take off the metal piece and put a plastic piece in there. So all of our stems now are really forward thinking, and there's a lot of technology that's coming out. So one thing that I do with each shoulder replacement, and this is more technology stuff too. So every patient that needs a shoulder replacement, I send them to get a CT scan. That's step number one. With that CT scan, and I brought a poor model, but we can play with where we place the base plate on the humerus. The biggest concern with reverses initially was that there's not a lot of bone stock. So if you need a revision, what are you going to do? Because this was initially kind of a salvage procedure, the reverse was. Because once you get out here in the body of the scapula, this is paper thin. You're not getting purchased with screws. You're not going to be able to hold your implant in. We've come up with different ways to address that, and I'll touch on that here in a second. But anyways, with the software planning, we can plan where we place this. We can plan the trajectory of the screws. So that's all thought about beforehand. And after we kind of finalize that, we can run simulations to make sure we have the best motion, least amount of scapular notching down here. And then they ship that information to a company that gets these 3D printed guides. So now, depending on the company that I use, there's 3D printed guides with all that information built into the guide itself. So that when I come up, I just slap this on their shoulder. It's built for them. I've already thought about my trajectory of my screws, so I'm not eyeballing it, trying to make sure I'm in the right position. It's built into this. It holds me there. So that speeds up the surgery. It enhances the outcome, your function, because we're putting it and we've run simulations. And even more exciting than that, classically the base plates, this part was flat metal. Well, the glenoid is not a flat surface. It's a concave surface, somewhat. So you had to shave down some of the bone, taking away bone from the area that's not a lot of bone, to put a flat metal piece here. Now, Stryker has, I sound like a Stryker promoter, but I'm not. I just use their product. Now they have 3D printed metal base plates. So the implant is built for the patient to match their anatomy, so that when I go in there, I've already planned out where I'm putting all the screws. This fits their anatomy perfectly, so I just kind of scrape the bone a little bit or any cartilage that's there, and this fits perfectly for their shoulder. These also, they're kind of porous and grip blasted so that the bone goes into the metal, helps with stability as well. There's up to 5 different screws that you can use, good fixation. So that whole process takes about 4 to 5 weeks. So when I sent them out, and I said, okay, we're going to book you 4 to 5 weeks out from here. Now, earlier I touched base on the glenoid bone loss. So initially, this was a salvage procedure. We didn't know what to do if we're going to have to go back in. Here's a patient with horrible dysplasia of the glenoid, not much bone stock there. They have an implant now, a vault reconstructive system. So they have also 3D printed metal, these base plates that can kind of make up any bony defects. And you get multiple, there's 1, 2, 3, 4, 5, 6 different screw sites on this one. It's going to be different depending on the glenoid, but you get a lot of different points of fixation, and you get this to match their anatomy. So this is a great salvage procedure that we have now to kind of help with those concerns with doing the reverse in the first place. What happens if they need a revision? The plastic as well. This is a vitamin E treated plastic. A lot of the literature that we have now, when we talk about the need for revisions down the road, and a lot of it is focused on the knee, right? Everybody talks about waiting as long as you can before you get a knee replacement because you're going to need a revision. Well, that was based on the plastic that we were making 20 years ago to get the 20-year data. We've made refinements in the plastic itself because that's what wears down. That's why most people need a revision. That we think that the plastic is going to last longer, and the shoulder definitely, because it doesn't see the load that a hip or a knee does. I tell most people, if you get a reverse, this will outlive you, this plastic. So I think we made good refinements in the plastic as well. The vitamin E is more for younger people. For whatever reason, it imparts some stability to the plastic from breaking down. And this is a kind of a picture of what that software looks like. And there's so many different things that you can play with as far as positioning, measuring your screws. And that also tells me something when I'm in the surgery too. If I'm measuring a 20 millimeter screw, but I measured on the plan a 40, then maybe I did something wrong and I placed it wrong. So those are the little guides to just more information for us. This is kind of talking about everything that I just talked about. These are the different kind of base plates that we have. We now have off the shelf 15 degree to build up if you have, but for most patients I'm doing the 3D printed metal base plate anyways. So this is looking at the traditional approach to do a shoulder replacement. You have to take it down, but then you have to manage all these sutures to repair everything afterwards. It can become a rat's nest of sutures and a hassle. But with this subscap sparing, I'm going in between the supraspinatus and the subscapularis. I have special instrumentation made just to cut from top down to keep my 25 degrees of retroversion and 130 degree neck cut angle, and to be able to do it in this tiny space. This has been studied, so it's not something that's, I'm not a cowboy, other people have done this too. And all the studies so far have shown, initially they're concerned, are there going to be more complications? That's been disproven. But the biggest thing that everybody has seen in the literature is that it's just a quicker return to function and motion. And somewhat less pain because you're not healing from the rotator cuff. This is just kind of talking all about all that. So with the traditional approach, you have to cut the tendon, requires a repair. Most of us use a sling for 4 to 6 weeks. I do 4. And it takes a while to for that tendon to heal and to recruit the muscles and a little bit of atrophy from holding your arm down here for so long. With the cuff sparing approach, I've been telling people, wear the sling for a day or 2 and then take it out of the sling. Start using it. Start reaching up, doing things to kind of recruit those muscles, get the shoulder moving, and get you on your way with recovery. And that's it. I think I have a couple videos as well of the subscap sparing approach, people.
Will you be developing your own approach and coining that the Jiffy shoulder?
I've looked into this. I'm still looking into this. This is a guy, he's a week out.
Still quick range of motion. Let's go up like this as far
And he had a Hemi because he had good cuff. He had mainly humeral arthritis, and I thought he was a great candidate. So 1 week out without a sling, he's doing all this. It's decent, but then I have the 6 week of him as well. Here's a 6 week, which I haven't seen many shoulder replacements doing what this guy's doing.
Scott, how many days out or how far out are you from surgery?
I think you can hear it too.
6 weeks.
Yes, sir.
And what surgery did you have done?
I had the humeral head replacement.
Yeah, so hemiarthroplasty.
Okay.
Yeah, but it was a cuff sparing one,
Yes,
right? And
yes.
we did the pyrocarbon. So let's see your motion. Let me see you go through the motion real quick. Come here at your
That's
side.
6 weeks.
Rotate out this way. Now reach up your back. Good. And how much pain are you in?
Not much. I'm working through all of it in physical therapy, and it's almost there. I'm about 95%.
What about your strength? How you feeling with strength?
Getting there. I'm getting strong again.
You
Yeah.
lifting weights again? Good.
Back lifting weights again.
But
6 weeks.
How's it feel compared to prior to the surgery?
100% better.
Yeah.
Yeah. It was definitely worth it. Yes.
And what would you say to someone kind of debating having this surgery?
Do it. Don't hesitate. It's a great procedure for sure.
All right. So that's all I had for you guys. Now, any questions?
Do you do revisions on someone else's primary?
Yeah, I've done everything. I've done proximal humerus replacements. Yeah.
With that?
Yeah.
Sure.
If we had a patient that we wanted to send to you, how do you prefer that to happen? Just have them call your office? Do you want any notes or anything from us before they see you?
Probably the easiest thing that I've been doing, or the most surefire way, is just having people reach out to me
Okay.
with the name and a number and any maybe insurance. I'll put that to my team and have them reach out and get them an appointment. And my cell phone works great, even with my patients. If you guys ever have any questions, I respond. I try to when I can, but I will respond, and I'm receptive to that, and I'm open to that. So, yeah.
What's your expectation for overall range, say overhead motion, for each of those procedures? Because a lot of patients frustrated they have higher expectations and come back with that information from the PA or from the medical assistant or from the doc. So what are your expectations in terms of each of those procedures?
With the balloon, I would expect them to be able to return most of their motion. With any of these procedures, males, stronger males, typically can get their full motion back, if not improve. Females, especially skinny females, I tell them it's going to take a long time. This will take a year for you to get to your new motion, whatever that may be. With anatomics, I tell them to expect to get to near full motion. With reverses, I tell them to expect to get to here. I expect you to be able to touch the top of your head. Some people get here, some people get here. I'd say on average, maybe right here. Reaching behind the back, it's going to take a year, regardless of what we do. That's always the last to come. And even reaching out, it just kind of depends on the integrity of the infraspinatus. So, like with an anatomic, I would assume normal. With the reverse, it kind of that's the variable. You may only get to right here. You may get to 45. I don't expect them to get to 80 or 90 or anything like that. But I always tell them anatomic, the pros and cons. The anatomic, you expect near normal motion. With the reverse, you're going to lose motion. Anatomics, in my mind, have a higher revision rate than the reverse too. So it's kind of a balancing act, weighing which is going to be the best option for them. But reverse, I always tell them you're going to lose motion. But a lot of times they come in and they don't have great motion either. So it may be improving, but it's not going to be normal again.
Do you have any precautions in terms of, say, go back to lifting weights, like what does that mean in general? Like, is there going to be a restriction where, like, hey, you're not going to be able to do certain things that you used to do with weights, like certain weight limits or overhead types of motions, or pressing or pulling or vertical pulling and that type of stuff?
With the balloon, it'll take a while to be doing weights heavily because, like I said, it's not held in place by anything. It is a fluid-filled sac, so if you're pushing heavy weights, especially overhead stuff, you're going to be really pinching that balloon. With the reverse and the anatomic, if I'm able to do a subscap sparing, within a month, I expect them to be able to be back in the gym doing something. It's going to take a ramp up. I don't expect them to go back to what they would have been beforehand. But within 6 months, I would assume that they're getting close to what their new baseline is going to be. I always tell them their shoulder's not going to be the same again. It's never going to be like a normal shoulder. But we'll try and get you as good as we can. And these are kind of the time frames that it should take you. Most people, I tell them, expect a full recovery, meaning that you've returned your function, you've gotten all the strength that you're going to get, and the pain isn't a daily thing, to expect a year.
Is there anything you would recommend for activity for them, just long-term, anything like to really avoid?
Any what?
Anything in terms of just long-term activities to avoid?
I tell a lot of older patients with any type of rotator cuff issues to avoid overhead stuff, like pushing up like this, because that's just pinching the tendon. That's what put them in there in the first place. So anything down here is pretty good, but I try not to get them pinching that tendon anymore. But after the shoulder replacements, not really. I think I would expect you to get back to what your normal baseline would have been before. They're never going to be as strong with the balloon either, because the subscap's gone, or the supraspinatus is gone. So you have a balloon, it's kind of helping, but you're not going to have, it's never going to be a strong shoulder like your uninjured sidewise. Anything else? I have some implants here too if you guys want to see just kind of what it feels like, what they look like. This is an actual stem from someone. Didn't take it out of them, it fell on the floor, so I got to keep it. So it's not dirty, don't worry. But yeah. All right, cool. Thank you guys.